Hi, in this lecture, we are going to continue our study of the cardiac output by looking at heart rate. Now, we talked already about cardiac output and we looked at stroke volume, so I'll just do a real quick overview of that. And then we're going to jump right into what are the main factors that affect our heart rate. So we'll be looking at the ANS, the autonomic nervous system. Remember, that is the parasympathetic and sympathetic divisions. We will look at some hormones, some ions, and then we have a category of other factors. So to review, remember that we have cardiac output, and cardiac output is the amount of blood pumped per minute. And the number we're using is 5 liters per minute is a typical cardiac output at rest. We know that cardiac output is one of the main factors that affects our blood pressure. And we know that blood pressure is critical because that's literally the force pushing blood to all of our organs. If we don't get blood to organs, they fail and they die, and then we die. So we know that cardiac output is dependent on 2 factors: stroke volume and heart rate. Last lecture, we talked about stroke volume. We mentioned the amount of blood pumped per beat. You might remember that that was 70 mLs per beat, and that can change. We mentioned the factors that affect stroke volume, and the number one factor that's not exactly on this slide is EDV. And remember, EDV was preload, and preload was dependent on venous return. So we talked about a bunch of factors that affected our venous return, and we also mentioned the filling time. And we know that EDV is one of the most important factors affecting stroke volume. We said it was a direct relationship. So if your EDV goes up, so does your stroke volume. And if your stroke volume goes up, so does your cardiac output, which ultimately raises our blood pressure. And then remember, though, the inverse is true. If my EDV goes down, then my stroke volume goes down, my cardiac output decreases, and blood pressure falls. So that was pretty important. We talked about contractility. So we had these positive inotropic agents. Remember, the positive ones basically boost the amount of calcium inside the muscle, so it contracts even harder, stronger, regardless of how much blood came back. It activates more cross bridges, and that is also a direct relationship. So positive agents increase stroke volume, which would then increase our cardiac output and blood pressure, while as the negatives, remember, decrease everything. And then afterload is your resistance. Afterload is not good, right? Afterload is the force in your pipes, and your heart has to contract harder and harder and generate more and more pressure to overcome that afterload. Because remember, that interferes with the amount of time you have to eject blood from your heart. So that's inversely related. So if our afterload goes up, right, that's our pressure, then our stroke volume will fall because we just can't get blood out of the heart. So that was the review from previous. Now we're going to look at heart rate. So chronotropic means time, it means rate. So we're really going to be looking at things that can speed up or slow down the SA node, because remember, the SA node is the pacemaker. So we'll look at factors that increase heart rate, and we'll look at factors that decrease heart rate. The number one factor affecting your heart rate is your autonomic nervous system. So remember that your autonomic nervous system, the headquarters are up in the medulla, so there's a section of the brain. And in the medulla oblongata, we are looking at 2 centers today. So we have what's called the cardio-inhibitory center, so that's shown as this light blue. And in the picture, you can see the cardio-acceleratory center as this kind of pink-red color. And the centers do exactly what it sounds like they do. The cardio-acceleratory center is going to send information to the SA node to try to speed it up. It's the accelerator for heart rate, whereas the cardio-inhibitory center is going to send information to the SA node to slow it down. And so I'm sure you're well aware that we're looking at the sympathetic and the parasympathetic nervous systems. And there's something called a cardiac plexus. And the cardiac plexus is a bunch of nerves. When we look at the cardiac plexus, we just talk about one nerve from there called the cardiac nerve. So the cardiac nerve is bringing information from the cardio-acceleratory center whereas the vagus nerve is bringing the information from the cardioinhibitory center. So we have two nerves that we'll be looking at as well. So let's look at what they do. So when we look at our sympathetic nervous system, we're looking at the cardioacceleratory center. So I'll just draw it right here. Let's just pretend this is the center, and it's in the medulla. A center is a bunch of neurons that have a similar function. And so their job is they're going to release and bring sympathetic information to the SA node. Now, it goes to the AV node as well, but we're not concerned. We're just going to focus on the SA node. So anytime we activate the cardioacceleratory center, a sequence of events occurs. The cardiac nerve becomes activated, and it carries information to the SA node. When it gets down to the SA node, those nerves are going to release norepinephrine. That's the neurotransmitter. It will bind to beta-1 receptors. You probably remember receptors from A and P1. They come back this semester. When norepinephrine binds to a beta-1 receptor, it's going to open sodium and calcium channels. Now, you might remember that anytime you open sodium and calcium channels, those ions are going to move into the cell. And we're looking at pacemaker cells, right? And we know they need calcium to depolarize. And so what will happen is it will increase the rate of depolarization, and it can even shorten repolarization. So ultimately, you're going to increase your heart rate. Well, if you increase your heart rate, you're going to increase your cardiac output, which means that will help raise your blood pressure. Now, if we look at the parasympathetic division, we'll just draw blue here, cardioinhibitory center up in the medulla. Now that center also is going to release information down to the SA node, and that's going to go through the vagus nerve. So don't worry too much about the drawings here. I was just drawing lines. You might remember, here's the vagus nerve coming off the brainstem in yellow. You might remember all this stuff from AP1. We're not going through the white ramus and the gray ramus and all of that. All we know, remember, the sympathetic's going to come down, and it's also going to get there. You don't need to know the exact path, know the name of the nerve. Vagus is carrying parasympathetic. Remember cranial nerve 10. When the vagus nerve releases acetylcholine at the SA node, it opens potassium channels. Now, remember, there's more potassium inside the cell. So when you do that, potassium will leave. Well, if you lose positive charges, you basically can hyperpolarize the cell. So it's going to slow things down, right? If you're losing potassium, and we'll come back to that in ions soon. So it slows it down, which means it's going to decrease your heart rate, which means that your cardiac output will fall, which means that your blood pressure will fall. And we've talked a little bit about vagal tone. Remember, we're always releasing some acetylcholine to keep the SA node a little lower than usual. So this would be increasing it more than that. So we have a reflex. We have a couple of reflexes we need to look at. And so reflexes, just like you might remember, you have information coming in. So a reflex carries sensory information in, and then it's going to go to a processing center, and then it's going to carry motor information out. So this is a little bit of a busy picture. I will draw this momentarily. However, and I'm laughing because if you've seen me draw, you might be chuckling too. But I want to go over this because I think it's a really good image. So we're going to talk about a reflex. So we know that a reflex, right, we're going to have information coming up to the brain and then information leaving the brain. So we're going to have mixed nerves. Remember, mixed nerves carry sensory and motor. We need receptors. So receptors, the first step in a reflex. And there's two types of receptors that we're going to be looking at. We'll be looking at the baroreceptors, which are shown as green, and we'll be looking at the chemoreceptors, which are shown as yellow. Now, baroreceptors, you probably remember, are going to monitor the stretch in the vessel. And so what we're looking at for the baroreceptors is they're located in two blood vessels. You're going to see them here in the aortic arch. See the arch? And then what happens is when the blood vessels come off the aorta and they come up your neck, there's an area up here that's called the carotid sinus. And the carotid sinus is where the common carotid artery, which comes up your neck, splits. into your internal and external. It's right at your angle of your mandible. In fact, you usually palpate this when you take a pulse. Now, both of these areas, by the way, aortic arch and carotid sinus, they're going to contain the baroreceptors, which are monitoring stretch, which is really monitoring blood pressure. Because if your blood pressure goes up, that vessel is going to stretch more. And if your blood pressure decreases, that vessel will stretch less. And so they're constantly monitoring too much or too little stretch to give information about blood pressure. Now, chemoreceptors are right next to them. Same locations, carotid sinus and aortic arch, but chemoreceptors monitor chemicals. And chemoreceptors for blood are only excited by 3 specific stimuli. So they are excited if your blood oxygen level decreases, if your blood CO2 level goes up, or if your blood pH falls. So those are the stimuli that are going to activate the chemoreceptor. Now, whether it's a baroreceptor or a chemoreceptor, now it needs to relay information up to the medulla, right? The medulla has to know what's going on. So I'm going to get rid of this so we can see. We will be looking at nerves. The vagus nerve was a mixed nerve. Cranial nerve 10. So what that means is that the vagus nerve will both bring information down, right? It'll bring motor information and release acetylcholine at the SA node, but it also brings information up. So it carries both sensory and motor. And the vagus nerve is going to bring sensory information to the medulla from the aortic arch. So any baroreceptor or chemoreceptor that's active in the aortic arch, that information is going to go up to through the vagus nerve to the medulla, to the cardiac centers, and that can trigger a response. Anytime we're trying to activate our parasympathetic division, the vagus nerve is going to carry that information out, so it's mixed. Now, the nerve that's going to carry the motor information for sympathetic, remember, we're just calling it the cardiac nerve, and that's going to be motor. That's just going out. We have another cranial nerve, however, that's going to help carry sensory information in, because remember, we also have sensory information in the carotid sinus. Well, the information from the carotid sinus is going to be transported through cranial nerve 9, which is the glossopharyngeal nerve. So we have cranial nerves 9 and 10 are both mixed nerves, and their job is to bring baroreceptor and chemoreceptor information up to the cardiac centers of the medulla. So they're bringing information up to the control center or the command center. Now, why are we worried about this? We've already said that cardiac output directly affects blood pressure. So if our cardiac output were to go up, then our blood pressure would go up. And again, these baroreceptors would be activated by the stretch. If our cardiac output went down, that would be a problem because then our blood pressure would go down. So this is a reflex response to your cardiac output and your blood pressure. So if you think about it again, if blood pressure goes up, let's just talk about the baroreceptors. You're going to activate the baroreceptors because there's more stretch. If blood pressure falls, there's less stretch. Remember, the baroreceptors are activated by too much or too little stretch. Well, how are you going to fix it? Well, we know that heart rate is a main control of cardiac output. So we can change the heart rate by changing the stimuli at the SA node. And if we change the heart rate, we can correct the cardiac output, and then we can fix the blood pressure issue that started it all. So if we're looking at the response, we have 2 situations in your notes for baroreceptors, blood pressure. So if your blood pressure were to fall, right? So there's a drop in blood pressure. That's not good. In fact, you would probably feel lightheaded or dizzy, or you could pass out. So what will happen now is the baroreceptors in the aortic arch and the carotid sinus, the green, are going to detect the decreased stretch. They will then send information up to the cardioacceleratory center using cranial nerves 9 and 10. Remember that the glossopharyngeal nerve brings it up from the carotid sinus, and the vagus nerve relays it from the aortic arch. So the input comes up, Now the cardiac center needs to reply, it needs to respond. And so the information is going to go to the cardioacceleratory center, because remember, my blood pressure is too fall. My blood pressure has fallen, it's too low. So if my blood pressure is low, I need to bring it up again. So now the cardiac acceleratory center responds. It's going to send the information down through the cardiac nerves. Remember, we're going to activate the sympathetic division. That goes to the SA node and releases norepinephrine. When norepinephrine binds to a beta-1 receptor, that's the type of receptor here, it opens sodium and calcium channels. Those ions flow in. I increase my heart rate. If I increase my heart rate, I increase cardiac output. Sometimes you'll see it written Q, and then that raises my blood pressure. So everything's fixed. So an example of this is when you stand up suddenly. So when you jump up out of your seat or you get up out of bed in the morning, when you stand up, we have gravity. Right?
I didn't get that.
And gravity's going, that was Siri, and gravity's going to interfere. It's going to drop our blood pressure a little bit. When my blood pressure falls, I need my baroreceptor response to kick in. And so what it does is this all happens very, very quickly, right? Within a couple of seconds. In fact, you might actually feel lightheaded for a second or two, and then it goes away because of the baroreceptor response. Now, we're going to talk more about this later, but notice that the norepinephrine binds to a beta-1 receptor. So if you're on a beta blocker, this is a medication that blocks that receptor. And so what that means is that norepinephrine can't bind. Well, if norepinephrine can't bind, it can't raise your heart rate. So if you have a patient on beta blockers, you got to be real careful with them. You don't want them, jumping out of the hospital bed or, going into like a hot tub because all the warm water vasodilates and drops your blood pressure. So you got to be careful because this baroreceptor response doesn't work as well in them. Well, what if the opposite happens? What if now your blood pressure goes up? It's too high. Baroreceptors pick up more stretch and they send the impulse up to the cardioinhibitory center this time. So again, we're still going to carry it up there through the vagus nerve and glossopharyngeal nerve. Remember, we still have them in the same location. This time, however, the vagus nerve gets activated, and the vagus nerve is going to carry the information down and release acetylcholine at the SA node. When you release acetylcholine, you open potassium channels, and potassium leaves. Now my heart rate falls, my cardiac output falls, and my blood pressure falls. So it's a reflex response that occurs. So I mentioned I wanted to try to draw this for you, and I think it'd be really helpful if you try to draw this as well. So instead of having you watch me draw it, I started the process. So I have my lovely heart here. Inside my heart, there's my SA node and my right atrium. The red are my blood vessels. So remember, the blood comes off. This is the aortic arch, this curve here. And as the aortic arch comes off, there's 3 vessels that come off of the aortic arch. The first one's the brachiocephalic trunk. The second one is the left common carotid artery. And this one here is the left subclavian artery. If we follow the left common carotid artery up the neck, it then splits. And it splits into what's called the left external carotid and the left internal carotid. Now, at that split is where we have the structure that's called the carotid sinus. So that would be this area right here at the split. And this is a place that you often palpate for a pulse. And then we also have, again, this area here is my aortic arch. Now, let's go up here. This gray area, just made it a gray rectangle. Piece of the medulla oblongata. Inside the medulla oblongata, I have 2 cardiac centers. This hot pink is the cardioacceleratory center, and the light blue represents the cardioinhibitory center. I'm going to use these colors for the relative nerves. We're looking at the vagus nerve, nerve 10, the glossopharyngeal nerve, nerve 9, as well as the cardiac nerve. Now, let's go through the process. We have both baroreceptors and chemoreceptors. Baroreceptors, respond to pressure, and chemoreceptors respond to chemicals. In particular, remember, they're going to respond to very specific stimuli. So they are only going to be excited if there's an increase in the CO2 level of your blood, if there's a decrease in the O2 level, or a decrease in pH. So it could be one thing that happens or all things. And a lot of times, if there's a problem with breathing and gas exchange, all of them will happen. So let's just go through the process. Let's say that the scenario that we're going to look at is, we're going to say if blood pressure decreases or your chemoreceptors are activated. So the same thing will happen anytime my blood pressure falls. It would activate the baroreceptors, or let's say that there's too much CO2 in my blood, okay? Or we could say there's not enough O2. So this is the scenario. We know that both the chemoreceptors and the baroreceptors are going to be activated by the either the decreased stretch or the increased CO2, because they're right there. And technically, could you have everything happening? Yeah, you could. So what's going to happen is we need to get this information up to the medulla oblongata. So my vagus nerve's job is to carry this information from the aortic arch. So it's going to come right up to the medulla. We also know that cranial nerve 9, my glossopharyngeal nerve, is responsible for carrying that chemoreceptor up from any chemoreceptor that's in the carotid sinus. So I have my receptors. They are activated by the stimulus. Okay, in this case, low blood pressure, high CO2, low O2, or even low pH. That is the stimulus that's going to activate the receptor. The receptor sends information up to the medulla oblongata. Now, in this case, we know it's coming up to the cardioacceleratory center, because if my blood pressure is low, I need to speed it up. If I have, too much CO2 in my blood or not enough O2, I need to get that blood to my lungs faster, don't I? Because I gotta get rid of the CO2 and pick up the O2. So the way to speed up the blood flow to my lungs is to increase my blood pressure. So these go up to my cardioacceleratory center. Now, once I get up to the cardioacceleratory center or cardiac acceleratory center, it's going to respond. And so it's going to send information out through the cardiac nerve to the SA node. That's my response. And then we know that when it gets to the SA node, it's going to hit it with norepinephrine, which binds to your beta-1 receptor. And when that happens, that's going to open both sodium and calcium channels, and that's going to ultimately increase your heart rate, which increases your cardiac output, which increases your blood pressure, and now you fix the situation. So I don't know if drawing it was helpful or not, but I think it would be something good for you to do as well, so you can kind of put all of this together. And then obviously if the opposite occurred, when we look at the opposite event, remember that we're only looking at chemoreceptors if the CO2 is too high or the O2 is too low. If the blood pressure goes up, these are no longer a factor because it's only one way for this. Chemoreceptor activation always increases blood pressure. There is no chemoreceptor input that would want to drop your blood pressure. But there is a baroreceptor response. So if my pressure is too high, same nerves get involved, right? Because they're mixed nerves, cardiac, glossopharyngeal, they're going to come up. But if my blood pressure is too high, now I'm going to want to lower it. So that's why I would use the vagus nerve, would come back down to the SA node as well. It has branches to it. And then we would go through the opposite, acetylcholine, muscarinic receptors, and then it would open potassium channels. You might remember the muscarinic receptors. Hopefully you do, from AMP1. They are the ones that bind acetylcholine. And now we're looking at potassium channels. So we hyperpolarize and we lower it. Now, we had mentioned a couple times this idea of vagal tone, autonomic tone. So just know that the vagus nerve is always dominant, keeping our heart rate low. And in fact, if you exercise regularly, if you do a lot of aerobic exercise, that actually increases your vagal tone. That's why your resting heart rate is lower. There are some things, though, that cause what's called a vasovagal reaction. So this is something that happens quite suddenly, and it activates the vagus nerve. And when it causes this like big surge in your vagus nerve and acetylcholine, it can drop your heart rate pretty quickly, which will quickly drop your cardiac output, and then usually you drop. So it can cause what's known as syncope, which is dizziness and passing out. So these are different things that can cause it. You don't have to memorize all of them, but one is sitting up too quickly or standing up too quickly. Stress, pain. Some people with sharp pain, this happens. Some people pass out when they give blood, venipuncture. Seeing something really unpleasant or really gross. And you can just see some of the different things that could cause this vasovagal reaction. Violent coughing. In fact, sometimes they'll tell you to cough really hard if you're having a fast heart rate. Another thing, by the way, to try to slow down your heart rate is if you do what's called a carotid massage. If you rub your carotid sinus, that's where you take a pulse, that activates the baroreceptor and it stimulates your vagus nerve to lower your heart rate. So sometimes you could do that as well. So that's some of the vagal tone. Now, the other thing I told you I would mention was hormones. And if you think about it for a minute, there are not any hormones that lower heart rate. Think about it. Acetylcholine is not a hormone. So our hormones all raise heart rate, and it kind of makes sense because the whole point is for your heart rate to go up to raise your blood pressure. And if you just think about a survival instinct, you know, if it's like, I don't know, 2,000 years ago and you're out walking and a saber-toothed tiger jumps out in front of you, you really want something to rapidly raise your heart rate, to raise your blood pressure so you can get out of there. You don't want a hormone to suddenly be released that lowers your heart rate and then you pass out and become lunch. So the hormones are going to always raise heart rate because that's more important for survival. And we have epinephrine and norepinephrine, which you probably maybe remember that they come from the adrenal medulla. Now, epi and norepi are hormones, but norepi is also a neurotransmitter, and they're pretty much the same thing, by the way. So anytime your fight or flight is active, you always release epinephrine as well from your adrenal medulla. And interestingly enough, epi tends to affect the heart the most, and norepi tends to work better on blood vessels. And then we have thyroid hormone, T4, from your thyroid gland. And so these are hormones that raise heart rate. And then we have ions. So when we look at ions, the two we're going to focus on are potassium and calcium. Those are the two most important ions when we're looking at cells and heart rate. So drawing a cell here, remember a typical cell has a lot more potassium inside. And same thing even with calcium, but let's just look at potassium for a minute. And so what that meant was because there was more potassium, potassium has a diffusion gradient, right? It wants to leave the cell. And in fact, potassium left the cell, which is what caused that resting membrane potential. So a resting cell, there's always more potassium inside. It wants to leave. You've seen this before. So some books will say minus 90, so I'm going to use minus 90. So the resting membrane potential is around minus 90 because more potassium leaves than sodium gets in. Remember, there were a lot more channels, and so we're always losing the positive ions. So that maintains the RMP. It keeps it negative. Now, if too much potassium leaves, then this number, this RMP, is going to fall. I'm making this up now. Maybe it's minus 100 because you're losing too many positive charges from the cell. If it's hyperpolarized, that's not good. It's going to be inhibitory on it. And we know, right, if we're looking at what happens when we look at cell physiology, is that we have our curve, something like this, where we depolarize and then we have to repolarize. So remember, when we repolarize, potassium needs to leave the cell for that. So the other thing to keep in mind is if too much potassium leaves, we're going to be too negative, right? You still have to get to threshold. You still have to reach that value to open all those sodium channels. We're not memorizing a number for threshold this semester, but you still got to get there. And if potassium doesn't leave, then it can't reset. It can't repolarize. So if we look at this and we see hyperkalemia, hyper having too much in my interstitial fluid in my blood, too much potassium around the cell, as you saw, that's going to interfere with potassium leaving the cell. It decreases the diffusion gradient. And when potassium doesn't want to leave the cell, it can make it more excitable. So in this image, it's a neuron, which is why you see minus 70. So we'll just make that a heart muscle and say minus 90. And we can see our normal. don't worry too much about the threshold number. Here's my normal kalemia, normal potassium. Hyperkalemia, more potassium outside, so it doesn't leave, as I just showed you. All right, it interferes, less will leave. Well, what that does is it makes the inside more positive. So it brings it up closer to threshold. So maybe instead of being minus 90, when we look at our depolarization, maybe it moves it up to minus 80. So it can make it a little more excitable. And then remember, when you repolarize, you have to have the potassium leaving. So now potassium does not want to leave. So it can actually shorten the repolarization time. So you might have tachycardia at first. You might not have a change in heart rate, but the heart will beat erratically. It will usually be weaker. And so initially it may speed up, but then as the potassium levels go up, it actually shuts down the SA node, which will send your patient into asystole or cardiac arrest. And often, but not always, hyperkalemia has a peaked T wave. So the T wave is usually tall and skinny. Now we contrast that with hypokalemia, that's less potassium around the cell. So we already said that that would make potassium's diffusion gradient go up. And so when we're looking at our hypo, you can see the picture down here, notice it brings everything down. So it makes it more inhibitory. Because more potassium leaves the cell, the inside becomes more negative. So we hyperpolarize the cell, which can slow things down and again cause weak contractions, arrhythmias, and send your patient into asystole. Sometimes on a EKG, you'll see an inverted T wave, or sometimes they're just like flat. Sometimes you see what's called a U wave, which we didn't talk about, but on an EKG, you can have, there's your T wave. Sometimes there's a U wave once in a while. So an EKG isn't always going to tell you if it's hyper or hypokalemia. However, if you do see the EKG change, it could be from that. So the best thing, I apologize for my dog, the best thing is to do blood work to confirm it. Now, calcium is the one that we need a couple times. So we need calcium in our muscle cell, and we also need it in our pacemaker cells. So I'm focusing right now on muscle cells only. So if we have a lot of calcium, we get more in our cell. That's going to give us a stronger contraction. Remember, it can increase contractility, and it might even slow down your heart rate. Whereas hypocalcemia, not enough calcium, is not going to be good. Your heart contractions will be very weak, and it won't work as well. So we also have to make sure we have enough calcium. And the other category is just real quick, age. So newborns have the highest heart rates. And then as we get older, they tend to be lower. And then caffeine, nicotine, body temperature, they all affect it. So in your notes, you have body temperature. You probably know that when your body temperature goes up, your heart rate goes up. And when your body temperature goes down, your heart rate slows down. Everything slows down in the colder temperatures. Caffeine and nicotine are stimulants. They increase heart rate. You probably know that. They basically mimic epinephrine. And there is a difference with acute versus chronic pain. Acute pain usually triggers that vagal response I mentioned, so it can drop your heart rate and make you pass out. Whereas chronic pain is a stress, and it can often result in a higher heart rate. So that wraps up our lecture on how heart rate affects cardiac output and blood pressure.